I'll go ahead and begin with some introductions. I know that there are a few more logging on. Thank you so much for being here today. I'm Elena Dinkin with the YMCA of Greater Houston, and it's been a pleasure to have this opportunity to partner with UT Health Neuroscience, going now on our third year on this virtual tour. It's really a great opportunity for all of our members to have this opportunity to learn and connect with physicians right there in their own home. And again, I oversee the Forever Well department here for the YMCA of Greater Houston, and welcome you to send me emails, connect with me, let me know how you're doing and what you hope to have for the support from the Y. So thank you so much. And again, I'm introduced now Elise Pratt with UT Health Neuroscience to help us kick it off. Thank you, Elise.
Yes, thank you, Elena. Hello, everybody. So just to tell you quickly who we are UT Health Neurosciences, actually UT Health Houston Neurosciences as of very recently. So we are the largest neuroscience provider in the region. We offer all aspects of neuroscience care from neurology to neurosurgery, radiation oncology, neuro-oncology, critical care, pain management, everything under that umbrella. And so speaking of pain management, we're going to talk about neck pain today. And so we've got Dr. Patel, who is a pain management specialist, and Dr. Hsieh, who is a neurosurgeon, to talk about different options for treatment for neck pain. So Dr. Patel, I'll let you go ahead and start.
Thank you, Elise, and thank you, Elena, for organizing this event. Hi, everyone. Good afternoon. Today, we're going to talk about chronic neck pain and options available for you for chronic neck pain. So let's get started. I am sharing this presentation with Dr. Joseph Hsieh, who's a neurosurgeon. Our clinic is located at the Southeast Memorial Hermann location in Medical Plaza 2. Here's an address listed on the slide with the phone number. We're south of Beltway 8 on I-45 South here. So here's a slide that shows a side view of the cervical spine. As you can see, there's the spinal cord that starts at the base of the skull and it travels down. It sends information from the brain to the rest of the body. At each of the spine levels, we have these small ports called foramens where nerve roots come out. It's a common place for a nerve to become pinched, and it can cause symptoms that we'll talk about a little bit later. We also have something called facet joints on the back side of the spine. These joints are there to help prevent any excessive or exaggerated motions of the spine, and it can also be a source of pain. We also have discs between each of the vertebrae that help with the alignment of the spine, that help provide height, as well as they are the shock absorbers for the spine. And then we have various ligaments around the spine, especially in the back and on the sides, that help keep the spine as a single unit. So there are some symptoms that you can have with neck pain that you do want to be mindful of. This includes pain, numbness, tingling or weakness into any of your arms, hands, and sometimes with chronic neck pain, you can also have pain going into your legs or feet. You may also have difficulty walking, unsteady gait, which can present as frequent falls. So you do want to keep track of any falls. You may have difficulty with grasping things, opening jars, for example, or difficulty buttoning your shirts. They may just feel very clumsy to you. That could be a sign of something going on in your neck. You can also start having headaches with chronic neck pain, and these typically start in the back base of your head, and then they can travel to the front. So you may want to be mindful of those as well. And sometimes you can have wrist pain that you do want to keep track of. There are certain conditions that go along with chronic neck pain that you want to get evaluated right away. These are called red flags. So anytime you've been in trauma, such as a car accident or a fall, and then you have neck pain that develops, then you want to get an evaluation urgently, which could mean a fracture of some kind or spinal cord injury. If you have fever, chills, and night sweats at the same time, along with neck pain, it could mean an infection of some kind. If you have unintentional weight loss, it could mean possibly cancer that you may want to rule out. Or if you're having new weakness, numbness, bowel or bladder incontinence, you also want to have that checked out, along with just pain that's just not going away, intensifying or becoming more frequent. So what do you do when you have any of these symptoms? You can start by seeing your primary care doctor. They will ask you a series of questions followed by an examination. They will make sure you don't have any of the red flags that we talked about. If you do, then the PCP may ask you to come see one of the specialists, like a neurosurgeon, right away for an evaluation and treatment. If there aren't any red flags or any numbness, weakness, etc., then it may be treated conservatively with anti-inflammatory medications, muscle relaxers, sometimes opioid medications. And you may be asked to take it easy for some time and then asked to come for a follow-up. And then during follow-up, PCP will evaluate you again to make sure the symptoms are getting better. If they're not getting better, then maybe an MRI, an X-ray, CAT scan may be ordered for you. And then you may be referred to come see one of us, a pain management specialist or a neurosurgeon. Making sure you have good ergonomics is important, such as a good posture if you're working on a computer, if you're driving frequently, making sure you're not lifting heavy objects. If you are lifting properly, avoiding excessive bending, twisting, all of those can be preventive measures to avoid chronic neck pain or back pain. So prevention is important. These are some of the neck conditions you may be diagnosed with when you come see your PCP or when you go to an ER or come see a pain management specialist or a neurosurgeon. And it could be a problem related to a muscle, a tendon in your neck, a problem with a disc, a problem with a joint, for example. Any of these conditions can cause inflammation in your neck area, which can put pressure on a nerve or a nerve root that's coming out and cause some of the symptoms that we discussed. So what are your treatment options for chronic neck pain? Typically, if you don't have any of the red flags, you want to start out with conservative treatment, which includes taking it easy, but avoiding bed rest. We don't want the muscles to atrophy around our neck. And we want to continue to have a good range of motion. So if you do bed rest, sometimes you can have restricted motion that develops over time. You want to start with some pain medications, such as anti-inflammatory medicines like ibuprofen, naproxen, Tylenol is also good, muscle relaxers. Nerve pain medications may also be prescribed if you have a pinched nerve, and sometimes opioid medications. You may develop some side effects with these medications, which tends to limit the amount that you can take over time. Sometimes a collar may also be given for a short term to help with pain. You may also want to try physical therapy to strengthen your neck muscles to help improve your neck posture, to improve your flexibility, range of motion of the neck. You also want to stop smoking if you do smoke, because it's important for bone health and chronic neck and back pain. And then lastly, you may want to see pain management for consideration of injections. If conservative treatment fails, or if you have any of the red flags discussed, you may be asked to see a surgeon. And then like Dr. Hsieh, and he would go over your surgical options at that point. So these are some of the injections that pain management like myself would be able to offer you for chronic neck pain. These are good injections to use as a tool for chronic neck pain. It can help improve your daily function by more than 50 to 70%. It can also reduce your need for oral medications, which is good if you do end up having a lot of side effects with oral medications. These are a great alternative. It can also reduce or delay your need for surgery or eliminate that need completely. Some of these injections are done under X-ray. Some are done without X-ray. Some involve injecting steroid and numbing medication. And then one of the type of injection involves injecting Botox. So occipital nerve blocks are a type of peripheral nerve blocks that are done for posterior scalp, base of the head, or neck pain. We have these two nerves called greater occipital and lesser occipital nerves that run very superficial in the scalp area, which can easily get irritated, can cause burning, tingling pain at the base of the head, headaches, neck pain. So we can inject a mixture of a steroid and numbing medication into those areas to reduce its irritation and inflammation, and that can help with pain. These can be repeated 3 to 4 times in a year, and it should provide pain relief for up to 3 to 6 months at a time. You can also try trigger point injections for tight muscles in your neck area. So this is an illustration that shows possibly some of the trigger points along the different muscle groups in your neck. I would be able to examine you and find those trigger points, at least the most painful ones. And then I would be able to inject a mixture of a steroid and numbing medication into those trigger points to reduce the inflammation and to relax those muscles. And it can help significantly with muscle pain. These can also be done up to 4 times in a year. So this is an illustration that shows a pain management specialist using a fluoroscope or an X-ray to guide needle placement for some of the different types of neck injections. We do have a procedure suite here at the Southeast Clinic, and I will be doing injections here in office for my patients. Cervical epidural steroid injection is a type of an injection that is done under X-ray. It is done for neck and or arm pain due to pinched nerve. And it's done from the back where we inject medication into a space called an epidural space, and that typically lines the spinal cord. And a mixture of a steroid and numbing medication is typically injected into that space. And that can reduce any inflammation around an irritated nerve and can provide significant pain relief. These injections can be done up to 4 times in a year and can help significantly with the pain. Another type of an injection that is done under X-ray is a cervical facet joint injection or cervical medial branch blocks. And both of these injections target pain related to inflamed joints in your neck area called the facet joints. And it can help with pain, sometimes headaches, as well as stiffness associated with chronic neck pain. You can either inject into the joint called the facet joint injection, or you can block a nerve called a medial branch nerve that typically provides the sensation to the joint. If you notice a significant pain relief with these injections, you may be followed by a procedure called radiofrequency ablation that involves burning these medial branch nerves. And the RFA procedure can provide pain relief up to a year. Lastly, you may be considered for Botox injections. Botox injections have been approved for chronic migraines as well as cervical dystonia. With chronic migraines, we have found a lot of patients have significant neck pain, and part of the injection sites include back of the head as well as the neck muscles. So by undergoing Botox injections for chronic migraines, you can have improvement in your neck pain. In the case of cervical dystonia, you can have overactive muscles that lead to abnormal posturing of your neck, where your neck is rotated or tilted in a certain way. And then it just becomes very persistent and chronic over time. So by injecting Botox into overactive muscles, we slowly relax those muscles to get the neck back into its normal alignment. And that can also help significantly with neck pain. So these are some of your treatment options from my standpoint, pain management. So if you are suffering from chronic neck pain, please come out and see us at the Southeast Clinic and we'll take great care of you. Thank you. I'm gonna give Dr. Hsieh the stage. Should I stop sharing? Okay.
Hi. Excellent. Okay, can everyone hear me? I guess this is working. Give me a second here.
Yeah, we've got you.
All right, excellent. All right, so my name is Joseph Hsieh. I'm going to share my slide presentation. Give me a second here. Okay, let's see. All right. Again, my name is Joseph Hsieh. I am one of the neurosurgeons with the UT Health Neurosciences. I work with Dr. Patel here at Memorial Hermann Southeast. Just an introductory slide. I have no conflicts of interest and no financial disclosures to disclose. I went to medical school at Harvard, did my residency at University of Chicago, and a spine fellowship at Cedars-Sinai in Los Angeles. I've been here for about a decade now. I'm the clinical director of neurosurgery here at Memorial Hermann Southeast. I'm one of the unaffiliated neurotrauma consultants for the NFL, assistant professor of neurosurgery, and then also do spine cranial trauma at Memorial Hermann Texas Medical Center. This presentation will hopefully be about 20 minutes or so. And we're going to cover neck pain with a couple of points, starting with background, then going to anatomy, causes, when you should see someone, how we evaluate and treat neck pain, and then how you should select your provider. Okay, I am actually going to stop sharing my screen because the rest of this is actually going to be basically presentation and discussion with myself. Give me a second. Let me see if I can make this a little bit larger. Excellent. Can everyone hear me, see me? Okay, perfect. All right. So what is neck pain? Neck pain really means different things to different people. For the most part, we think of the neck as this region here. But we actually, when we talk about neck pain, also care about headaches, specifically headaches going over the back of the head, as Dr. Patel has mentioned, as well as pain radiating down the arms and the upper portion of the back. It's very important to be able to differentiate where exactly the pain is, because it leads the provider in understanding exactly what potential causes could be, and then also what the treatment options could be. To take an understanding of exactly what this is, I'm going to talk a little bit about the anatomy. I've got a model here. And so this is the spine, okay? And so this would be the front. right there. This is the back. And what you're going to notice is that it's going to be made up of bones. There are discs in between. In the back, there are these spiky bones called spinous processes, and then bones over here called the lamina. And then this big yellow nerve that starts from the brain that goes all the way down through the middle, you can kind of see, that's the spinal cord. The spinal cord will shoot off individual nerve roots that come out, and they come out through these holes off to the side, and they're called foramen, okay? And so we will discuss various sources of your pain and also various treatments for your pain based upon the anatomy, okay? If a pain is shooting down the arm, then oftentimes it's a nerve root that's affected, and we call that a radiculopathy. If you have weakness, numbness, pretty much everywhere, then that could be a sign that the big nerve, the spinal cord, is affected, okay? There are various other ligamentous structures that you're not going to be seeing. There are ligaments that hold the back of the spine in place. There are ligaments that hold the front of the spine in place. In the front of the neck, obviously, there are blood vessels, nerves, muscles. There's your feeding tube, which is the esophagus. There's a breathing tube, which is the trachea. Those are all part of things that can be affected, and they can all cause pain. For the most part, though, if you're coming to us as a neurosurgeon or as an orthopedic surgeon or someone else who treats neck pain, we're going to be dealing with these structures that you see right now, okay? Now, the question is when you should see someone. So we break off pain into 3 separate phases. We say acute, which is usually less than 6 weeks, subacute, which is between 6 weeks and 3 months, and then chronic, which is greater than 3 months. Now, it's important to differentiate how long you've had your neck pain, because most types of neck pain will disappear within the acute phase, within 6 weeks. And that's because your body will figure out some way to manage that pain or deal with that pain. Some of the muscles may heal, some of the ligaments may heal, some of the discs may actually disappear if they've herniated out. So we give it some time before we actually jump into something a little bit more aggressive. In the situations where the injury, even in that acute phase, can be permanent, we sometimes intervene. So these will be situations where you have severe weakness, or you have severe debilitating pain that we can't treat, or there's some kind of instability to the spine. Those are times where we have to jump in even earlier than that 6-week time point, okay? Now, let's say that you've had your pain for an extended period of time, it's really not going away, or you're worried about it. Those are times that you absolutely should go and see someone. Okay, whether it be a spine surgeon, your primary care doctor, but you should see someone. Okay. We break down the causes of pain into 3 main categories. They can be mechanical. A joint can be, a little bit arthritic. Some of the muscles can be torn or strained. Those are mechanical sources of neck pain. They can be neurologic. They can be due to a compression on the nerve, a compression on the spinal cord. They can be other types of pain. And those would be, whether it be due to a tumor, an infection, possibly a blood vessel or vascular source, maybe even referred pain. Maybe you've had a heart attack and caused pain down the arm, okay? So those are all separate types of pain. And it's our job basically to try and figure out which ones. In order for us to do this, we have to do an evaluation, okay? And the parts of the evaluation are really divided into 4 main parts: getting a history, doing a physical, running imaging and tests, and then basically trying to understand what else has been tried, okay? So when we talk about a history, we've already talked about what the time frame is, what was the trigger, what have you tried to treat it with. In the physical exam is basically us trying to determine, while we're seeing you, what cause the pain is from. Now, you might think, why don't we just look at the MRI? And oftentimes the patient will come to me and say, did you see my MRI? And I have seen the MRI, but the reason I'm seeing you and having you come to clinic is because more importantly than the MRI is what's going on with you. And what we'll do is a very, very detailed exam going by muscle group, because each muscle group is going to be associated with a different nerve. For instance, the C5 nerve, which come out between the C4 and C5 bones, will be responsible for your deltoids. So I will be doing a deltoid exam. I'll be doing a biceps exam, triceps. I'll be testing peripheral nerves. I'll be testing range of motion. I'll be testing if there are any lumps or bumps, any points of tenderness, seeing if I can trigger or elicit any types of pain, if I can identify any types of other sources of pain, like is your shoulder out of joint, okay? And so it's very, very important that you go to someone with more than your MRI, with the understanding that they're going to want to know where your pain is, how long you've had your pain. And the better that you can explain that to your provider, the better it is that they can hone in on exactly what's wrong, okay? All right, so your provider has now looked at your MRI, now done the physical exam, now taken a history. We talk about exactly what we can do. So we talk about that 6-week time point. If you don't have something that's a red flag, then oftentimes we'll provide some of the conservative options of treatment, which Dr. Patel has mentioned. Other things that we also do quite a bit of is physical therapy, directed exercise. We try to help you get back to as much activity as you possibly can with understanding your limitations. We also understand that we are not here to waste your time, okay? Our group is very, very conservative. We do not offer surgery until it's absolutely clear that nothing else is going to work. And also, unless it's clear that we can actually do something to help, all right? Now that we're talking about surgery, what are the goals of surgery? So the goal of surgery for us will depend on exactly what you have. For the most part, it'll be to improve pain, improve neurologic function, or at least prevent its deterioration. And I'll go into that, exactly what that means in a little while. We will oftentimes try to provide the absolute least in terms of surgery that we can to get the job done. And the reason for that is because you do not want someone to try and instrument every single portion of your spine, because it's going to completely change the way that your spine functions. If someone throws in rods and screws everywhere, throws in plates and grafts everywhere, then yes, they may be able to help you with your pain for a short period of time, but your neck is still designed to move. You're going to be moving your neck. Something can break. The areas above and below where you've had the instrumentation placed in is going to feel a lot of stress. It's going to wear out. Your neck is going to feel awful in about a few months to a few years. If something too much is done than it should be, okay? All right, I'm gonna go ahead and share my screen again so that we can go through a couple of examples. Let's see. All right. So this is a 38-year-old woman with 2 weeks of right-sided neck pain and shoulder pain. This is an MRI. You can see my little mouse here. This is the face, front of the neck, back of the neck. These are those bones. These are those discs. This is the big nerve called the spinal cord, okay? Over here on this side, this is a picture from a top-down view, basically going across this line right here. This is the front of the neck. This is the back of the neck. This is the right side. This is the left side. This area here is this disc right here. This area here is the spinal cord and the spinal fluid around it. That's a spinal cord. That's a spinal fluid around it. It corresponds to this portion right here, okay? Again, this is the right side. This is the left side. You're going to notice this person has a big bump of stuff sitting right behind the disc. This is the disc. Here's that bump of stuff. It's on the right-hand side. These are where the nerve roots come out. This bump is pushing against the right side of the nerve root, okay? This is between second bone, third bone, fourth bone, fifth bone. So this is between C4 and C5. We talked about the C5 nerve being responsible for the deltoids. This woman had deltoid weakness. She had pain going down the right side of her neck, going down to the right portion of her arm, about right here. And she had a herniated disc, basically coming from here, pushing against the nerve root, causing her pain. All right. So we treated the patient. And then after a few months, we got another MRI. And this is what it looked like. 2, 3, 4, 5. No disc here. No disc here. You don't see any rods or screws or plates or anything else like that. And this is because we did the absolute most minimally invasive surgery possible, meaning that we didn't do any surgery. We let the patient wait for about 2-3 months, and the body took care of the disc itself. Before someone recommends the surgery on you, make sure that there's the possibility that it won't go away by itself. Okay, so we're very, very conservative here. We only operate when we absolutely have to. All right. Now, this is a woman with clumsiness and balance issues for about a month. You'll see patient has a large disc herniation here, another disc herniation here. You can see the spinal cord being pressed. There's some white signal within the spinal cord. Same thing here, big disc pushing and flattening the spinal cord. The spinal cord is a nerve that you don't really want to play around with. The spinal cord is one that, once it's injured, can oftentimes have a permanent injury, which basically means that there's a risk of permanent weakness, numbness. The person was already becoming clumsy and having balance issues. This is not someone that we could wait on. All right, so we offered a surgery. In this situation, we had to take out the disc from the front of the neck. We took out this disc, we took out this disc, give the spinal cord some room. Now, the way that we did this was we used something called an artificial disc. And the artificial disc is one that basically allows there to be some movement in the neck. You see a metal plate, and then there's a radiolucent, meaning that you can't see it, piece of plastic that sits in between here. There's one here, there's one here. This allows movement in the neck. It reduces the strain at the levels above and levels below because you're not fusing the neck. If you had fused this would be one long stick, and then because the neck is still moving, there'd be a lot of stress here and a lot of stress here. Again, we're trying to reduce the amount of change in the normal function of your body. So the artificial discs are a good option for this patient. If a surgeon is only offering you one option, make sure that you think about whether or not there are other options for it. Oftentimes, it's not unreasonable to get another opinion if you are concerned. Make sure that whoever it is that's treating you has a good reputation. In this situation, the artificial disc is alternative to fusion, and it has good long-term outcomes in many circumstances. All right. Sometimes you really don't have the option of doing something fancy. You don't have the option of doing something minimally invasive or trying to preserve motion. This was a 27-year-old woman who basically lost control of her car. She's had a large fracture here of this bone. This bone is pushed into the area where the spinal cord would be. Top-down view, this bone is shattered across. This looks a little bit different than the previous images because this is a CT scan and all you're seeing is the bone. Okay, but showing you the fractures a little bit better. An MRI was also done. You can see that the spinal cord looks awful. It's being crushed. It's got a lot of swelling here. There's actually blood products within the spinal cord. This is a top-down view. This spinal cord is horribly unhappy. And the situation, we have to do a larger surgery. We have to put a plate, we have to put a screws, we have to put a titanium strut in the front, we have to put rods and screws in the back. When we have to do something larger, we have to do something larger. Here's another woman in a trauma. She's 77 years old. She was in a car crash like the other woman. In this situation, this bone here, this is a view a little bit off to the side, fractured the bone right smack dab down the middle against the top-down view across like that, okay? In this situation, however, we can do something a little bit fancier, okay? Again, we're trying to preserve motion. We're trying to preserve the overall function as possible, okay? Something that could be done is called a fusion, where we put in screws above and below, lock that in place so that this fracture doesn't have, doesn't cause any instability. But another thing that can be done is actually realigning the spine and then putting a screw directly through the fracture line, kind of like you would through a knee. And so in this situation, we've only put in one screw. This realigns the bone. This bone is healing, and we have not taken away any motion. Here's another example. She's a 34-year-old woman who's fallen down a water slide. Very similar fracture, again, through the second bone. You can see this angled forward, basically causing a fracture all the way across. Oh, sorry. Go back. What we did was we realigned her. She's 34 years old. She's young. She makes excellent bone. We used a absorbable suture, something that the body will, over about 6 weeks to 2 months, absorb, realign the spine, and then over time, the suture reabsorbs and the fracture is healed. So she gets away without any rods or screws or anything else like that, with the fracture healed and realigned, when otherwise you would have had a fusion. The final part that I want to talk to you a little about is how you want to select your provider. And so this becomes a philosophical discussion. What you want is you want someone who obviously knows what they're doing. So you want to look for someone who has some degree of experience in dealing with the spine and dealing with all aspects of the spine. You want a provider that has access to pretty much all the other ancillary services, whether that be physical therapy, rehabilitation, neurology, orthopedics, someone who can have, where you can get all of your care done at a one-stop shop. And that's important because the discussion between the providers is going to be very, very important to make sure that you get good quality care that's complete. All right. Looking for a provider that specializes in your own condition is useful, but probably what's even more important is seeing a provider that's going to be paying attention to you, that has a good reputation inside the community. Okay. With that, I'm going to pass it along. This is us at Memorial Hermann Southeast. This is our staff in the front office. Obviously, we work with Dr. Patel. We do offer basically a one-stop shop, as we discussed, for pretty much everything. And we're open up for questions.
Awesome. Thank you, Dr. Hsieh, and thank you, Dr. Patel. That was fabulous. If you have any questions and you have not put your question in the chat, please go ahead and do it now, and we will go through them. And you'll see on your screen right now, and I also put in the chat, contact information for how to reach us if you wanted to find out more about us or schedule an appointment with our physicians. Let me start going through the questions here in the chat. Let's see, we had several. Going back to the top. This one is non-surgical. So Dr. Patel, I think we'll start with you. This person had neck pain for 15 years since menopause, interested in non-surgical treatment interventions. For example, can you inject a substance like cartilage in between the discs for degenerative disc disease?
Something that I have not come across from my standpoint for pain management. I'm not sure if Dr. Hsieh has input on this.
Sure. So the short answer is people will inject all sorts of things into the spine. And you can find various types of treatments. sometimes, most frequently internationally. In the cervical spine, usually something like what you discussed is not done. But I've seen people try to inject stem cells into the discs, stem cells into the joints. You have to be very, very careful about who you're getting these types of treatments from, because oftentimes they are not regulated. And I've seen a lot of infections or a lot of complications from people doing very, very strange things. But short answer is, in the cervical spine, no, I've never seen anyone try to inject a cartilage or anything else like that into the neck. Part of it is because you actually are going to need a surgical procedure to access the front of the neck to get something in the disc there.
Okay, good. Another question, I've heard that neck surgery doesn't have a lot of success. Has this changed in recent years?
Sure. So the short answer is we have advanced neck surgery significantly, but again, the more important part to this is going to someone who knows what they're doing and has a good reputation in the society. There is a lot of surgery that is out there that can be done. That does not necessarily mean that it should be done. And so we do see situations where a neck surgery can be overprescribed and can oftentimes cause lingering issues down the line. So what I would say is that if you are considering neck surgery, then go with someone that's trusted in the community. More than anything else, be a little hesitant if you think that this might be too much surgery.
Okay, I'm gonna skip because I saw another one, and you might be able to give a little guidance here. It's interesting because I'm marketing, and it's kind of a marketing question in a way, but how can I get unbiased information about a neurosurgeon's reputation? What do you say when people are asking that? I'm curious too.
It's very, very hard. You're going to find very few surgeons who are going to badmouth other surgeons. Okay. One of the things that I can tell you is that there's not a great Yelp or something else like that for surgeons. It really does come down to, have they been established in the community for a while? And do they have a good reputation? And the best place to find that is, other people who've seen that physician. Is that physician being, is that physician in good standing with the community? Unfortunately, I don't really have a great way to answer that question.
It is tricky. And I think, if you have a physician that you've been seeing that refers you to a surgeon, that's often helpful because you know that at least they have a good reputation with that person. And, you can do some research on your own. Some people post, different groups will post their outcomes depending on what the organization is. So you can look into that and their volumes of surgeries too. But it's a great question. And it's something that patients do ask a lot. Okay, next question. The benefit of PT versus massage versus acupuncture. So if you're not doing surgery, what do you think of those?
I can take that question. So physical therapy, as we discussed during our presentation, it can help reduce pain. It can help strengthen any weak muscles that you have along the spine. So if you have stronger muscles, it can offload the pressure that's placed on the spine. So offload pressure from the discs, the joints, etc. It can help kind of improve mobility. So any restricted motions you have of your neck, if you're not able to turn a certain way, flex, extend, physical therapy can get you there, improve your mobility. And it can teach you exercises that you can do at home on a day-to-day basis. Massages are typically beneficial for tight muscles that you may have in your back of your head, neck area, upper back, you do want to be careful with massages. You don't want something that's too strenuous, or if it hurts too much, then it may not be a good massage for you. Especially going to a chiropractor, for example, for massages as well as possible manipulations. You may want to avoid any type of manipulations of your spine, especially cervical spine. Acupuncture is more 50-50. Research has shown that it helps some patients, but not all. It may be worth trying because the risk is very minimal with acupuncture. So if you do suffer from chronic neck pain, it's one of the conservative treatment options to try, but it may not help with neck pain that's stemming from the spine etiology, such as a pinched nerve, for example.
Great. One other general question that I think I can answer, but y'all are welcome to chime in. Do you accept Medicare? And yes, we do take Medicare and all major insurances. So you can find more information through our billing department if you wanted to message us through our website or through that email that I posted in the chat. Another one, my pain is on my upper right arm, close to shoulder. Who do I see, neck or shoulder specialist?
Well, it may actually be very, very hard to tell without actually someone evaluating. So the short answer, if you want to try this at home, actually, there's a very, very quick test to see whether or not something may be involved with the shoulder, most specifically the rotator cuff. And what you can do is you can hold your arm out forward, thumbs down, and have someone push down on the arm, okay? It's called an empty can test because you're dumping out a can. If you're having significant pain in the shoulder region, then oftentimes that can be a sign that you're having specifically a shoulder problem or a rotator cuff problem, in which case an orthopedic surgeon would be a good option. If you're having pain radiating down from the arm to the outside of the shoulder, okay, but it starts in the neck and is shooting down the arm, then more likely it's from the neck. And then come and see a neurosurgeon or a spine specialist of some sort.
Now I'm wondering if everybody is sitting there doing their thumbs down right now.
It should be.
Let's see. Where is Memorial Hermann Southeast? So that is over near, is it Beltway 8 and 45, Dr. Patel?
Yes, it is. South of Beltway 8.
Yes. And yes,
Field.
it's part of the Memorial Hermann health system. And yet they're asking if it's aligned with the medical center. So yes, the system is aligned with the Texas Medical Center Memorial campus. So we're all part of the same group, and our physicians, like I know Dr. Hsieh is sometimes at Southeast and sometimes at Medical Center. And so we kind of bounce around and have experience in all places. What options do I have that will help me manage my neck pain if I can't take NSAIDs due to having one kidney?
So you could try first lifestyle modifications, maybe trying a new mattress or a new pillow, trying exercises at home along with physical therapy. In terms of medications, we want to avoid NSAIDs overall long-term because it does damage kidneys as well as stomach lining. You could try other oral medications like Tylenol. It tends to be safer for the kidneys, and you can take that up to 3 to 4 times a day for pain. You could also try nerve medications. That is a prescription medicine that is given once you've been evaluated by your PCP, a neurosurgeon, neurologist, or a pain management specialist. You could also try muscle relaxers if you have tight muscles, along with these medications and other prescription medications such as opioid medications. So
I think one of the things that Dr. Patel had mentioned is that if you're having chronic neck pain, then see someone for it. And if it needs to be evaluated by a spine surgeon, then, see someone.
Yeah, that's a great thing to add for all of these questions. See somebody and make sure that you get it treated. I had a C5, C6 fusion 26 years ago. It was a great So that was a success, but arthritis has developed above and below the fusion, very painful. Can't take NSAIDs, metaxalone, muscle relaxer works, but I can't imagine taking this forever. What is next for me?
Well, I'll handle that. So we talked about putting in rods and screws and plates and then that affecting the levels above and below. And this is exactly kind of one of the common things that we see. The next thing for you would really be to see someone because it really does depend on how bad the degeneration is. There may need to be something else done. And what that next step would depend specifically on what your spine looks like, because spines break down in different ways. Sometimes they can be treated without surgery. Sometimes they will require surgery, but what that surgery is, can be from the front, can be from the back, can be additional instrumentation. Sometimes you can do without instrumentation, really depends.
Okay, we've got lots of questions. In the interest of time, I'm just going to try and get through a few more. Let's see, since I had chronic headaches. Okay, so this is a headache question. I had an injection on my face, which helped a lot. I think it was a nerve block. How often do you have those?
So when it comes to facial injections for chronic headaches, you can have injections done above and below your eyebrow called supraorbital and infraorbital nerve blocks. So you can be validated by a neurologist or a pain management specialist to determine if you would benefit from those. And typically, if you don't have any other medical conditions that would prevent you from getting these injections too frequently, they can be done 3 to 4 times a year. You can also have Botox injections where part of the injections are done in the frontal scalp, and those can be done also 3 times a year, every 3 months if it's indicated for you. So come see a neurologist, a pain management specialist, neurosurgeon for chronic headaches, and then we'll evaluate you before determining how often you can get these injections.
Great, and that's one thing I should note. Dr. Hsieh and Dr. Patel work in the same clinic, and that's the setup that we have across the city so that our spine surgeons and our pain management specialists work closely together to make sure you're getting exactly the right kind of care that you need. Okay, let's do 2 more. Dr. Hsieh showed an example of a case where dissolvable stitches were used to repair the broken bone. He made the comment that the woman made bone well. As people age, they tend to lose bone. So is the option he discussed in that case less available for older people in general?
Yeah, so that case, I want to make sure that I make sure that this is out there. It's not considered standard of care. This is one of the things that we've innovated here within our group. It's only used in very, very certain situations. There are times that a surgery is going to be available to you that's not going to be available to someone else. If you are older and you are not in the best health, if you're not making fantastic bone, we do have options to try and remedy some of that. However, not all surgeries are going to be available for everybody.
Okay, and do I have to have a PCP referral to see Dr. Hsieh? I think it depends on insurance, is that correct?
I am actually not the best person to ask that question to. Unfortunately, my fantastic staff is,
Yes.
or our fantastic staff, Hiral and mine, are going to be more involved with that than I am. So
I will put
sorry.
our information in the chat window, so you can feel free to call or email our referral team, and they can answer all these kinds of questions and more. I think that's about it for today. I know we're almost at 2 o'clock. Thank you very much, Dr. Patel and Dr. Hsieh. And Elena, I'll let you wrap it up.
Thank
Okay,
you.
so glad to have everybody here again today. Some technical problem with my video, but that's quite all right. We had a great turnout today and wonderful again with such support from UT Health Neuroscience. Looking forward to our programming next month. For everyone on the call today, I will be sending out a recording. Again, thank you so much to everyone for being here and for our physicians for taking the time today. Take care and everybody stay safe. Bye-bye now.
Bye.